everyone, and welcome to the Collaborative Family Healthcare Association's webinar series. We're pleased today to bring you a series sponsored by our Medically Unexplained Symptoms group. The title of the webinar today is Medically Unexplained Symptoms, Diagnosis and Treatment. As I said, it's sponsored by our MUS SIG. And let me tell you just a little bit about the Medically Unexplained Symptoms Special Interest Group. It was formed in 2016, and its mission is to promote the role of behavioral health integration in the care of people who present with common symptoms, which are often unexplained by a purely biomedical approach, and to foster collaboration and scholarship, education and training, practice, policy, and research in the field. We are pleased today to have two speakers with us, Dr. David Clarke and Tyler Lawrence. Dr. Clarke is a well-known professional in the field. He has conducted detailed interviews with over 7,000 patients with medically unexplained symptoms. He is president of the Psychophysiologic Disorders Association. He is also assistant director at the Center of Ethics and clinical assistant professor of gastroenterology emeritus, both at Oregon Health and Science University in Portland, Oregon. He is associate faculty at Arizona State University and at the Cummings Graduate Institute for Behavioral Health Studies. He is also a clinical advisor to the Stress Illness Recovery Practitioners Association in the UK and is a clinical lecturer with Pacific University in Oregon. Dr. Clarke is board certified in gastroenterology and internal medicine and practiced gastroenterology in Portland from 1984 to 2009. His book for MUS patients is titled They Can't Find Anything Wrong, and his website is www.stressillness.com. Dr. Clarke has lectured extensively on MUS and psychophysiologic disorders to healthcare professionals and the public across North America and in Europe. And our other speaker today, Dr. Clarke, is one of the chairs of our MUS SIG, and the director of communications for the MUS SIG is Tyler Lawrence. Tyler is currently earning his PhD in medical family therapy from St. Louis University. He is a pre-doctoral behavioral medicine intern at the University of Nebraska Medical Center in the Division of General Internal Medicine. There he engages in research, psychotherapy, supervises master's level marriage and family therapy students, and teaches behavioral health topics to healthcare professionals. Last but not least, he's getting married this spring, and we're very pleased to have both Dr. Clarke and Tyler presenting today. If you are interested in learning more about medically unexplained symptoms and joining the SIG, we invite you to do so at our website, www.cfha.net. In the opportunities drop-down, you'll see the special interest groups and this particular group, and we would invite you to join. They meet periodically about once a quarter, and once you join the group, you will be put on a listserv that invites you to future meetings. So with that, I'd like to turn it over to Dr. Clarke, and we will start the meeting.
Thank you very much, Polly. I really appreciate your putting this together for us, and welcome to everybody who's joined us today, and we appreciate your interest in this subject. I'm a traditionally trained gastroenterologist, which means that, like most physicians today, I was taught that there isn't much you can do for medically unexplained symptoms or for the related clinical problem of chronic functional symptoms or chronic functional syndromes. But it turns out that that's not true. And in fact, most mental health and behavioral health clinicians, using their existing training and experience, can make these patients a lot better. They can diagnose and treat them as successfully as we diagnose and treat almost any other condition in medicine. And the outcomes are, as you might expect, vastly improved. These patients are traditionally thought of as the most difficult and frustrating, but they can be transformed into some of the most gratifying and rewarding, because not only can you relieve their symptoms, but in many cases you also change their lives. The term that my colleagues and I who do this work prefer for this disorder is psychophysiologic disorders, and we like this because it tells you something about what's going on, whereas the MUS term really doesn't. The psycho refers to the psychosocial stresses that underlie the symptoms in these patients, and the physiologic tells us about the fact that this is not a magic process, that this is a physiologic process. As it says on the slide, most MUS are now known to be linked to altered CNS neuroanatomy, and we've learned this from functional MRI studies of these patients, which show that the areas of the brain that light up when the patient is experiencing pain are different than the areas that light up when healthy people are experiencing pain. So when patients are taken aback by any discussion about stress in connection to their illness, and they say, "What, you think this is all in my head?" we can reassure them that no, this is not imaginary. This is not in just quote-unquote in your head. It's in your brain, that there's a real neuroanatomic change that's associated with this in many cases. So there is a real phenomenon underlying it. As a cause of presenting symptoms in outpatient primary care, the numbers are enormous. There are a number of studies that coalesce around an average of about 30% of outpatient primary care, or about 1 in 6 adults in the general population, or about 40 million people in the United States alone. Many of these patients will improve on their own without any specific intervention, but there's a significant subset where the illness can persist for months, years, and even decades in some cases. My personal record patient was ill for 79 years. The presenting symptoms in this patient population are literally from head to toe. The only common denominator is that many of them will have more than one symptom. There's a paper out there that supports the idea that if a patient has 6 or more symptoms, there's a 90% chance that psychophysiologic disorder, or PPD for short, is what they have. But the range of MUS includes headaches, ringing in the ears, visual disturbances, temporomandibular joint symptoms, difficulty swallowing, neck pain, low back pain is a big one. Probably 70% of low back pain is psychophysiologic in nature. The full range of gastrointestinal symptoms, short of bleeding, which is how I got into this field, chronic cough, paresthesias of the extremities, joint pains. I'm sure I'm leaving some out. Pseudo-seizures is another one. Again, almost anything where there's no organ disease or structural abnormality that explains it, or the patient doesn't respond to treatment in the way that's expected. Next, we move to the diagnostic process for this patient population, and it's a 6-part process which typically will take longer than is available at any single appointment, but there's no law that says you have to gather all this information at one time. These patients often are those that repeatedly return to a medical office, and you can gather this information a little bit at a time. It starts with getting a good chronology of the illness, understanding when and where the symptoms began and what has been their pattern over time. And the importance of this is particularly in looking for chronological links between the symptoms and stresses in a patient's life. So if a particular stress began at the same time as a patient's symptoms, for example, that's pretty solid circumstantial evidence that there's a connection between the two. Or you may find that symptoms occurred at various times in a patient's life, and those happen to be times of particular stress. Sometimes you can make the diagnosis with this information alone. One of my patients, when we focused in on exactly when and where he was having his symptoms, it turned out it was only while he was driving to work. When he was driving home from work or on the weekends when he was not at work, he was completely asymptomatic. So that was pretty decisive just right there. Another patient, just one more quick example, he had daily back pain for over 25 years, except 2 weeks out of the year. And those 2 weeks were the time he was on vacation. The next step in the stress evaluation process is simply to inquire about stress in the patient's life at the moment. Almost anything bad that can happen to a human being, I have probably seen it cause symptoms in somebody somewhere over the last 25, 30 years. An important subset of this is insufficient personal time, and the question I like to ask here is, are you the kind of person that takes care of everybody else in your world, but you have difficulty putting yourself on the list of people you take care of, or you have difficulty taking a break and doing something pleasurable for yourself? And there are quite a number of patients like this in my practice. They simply are so busy taking care of the needs of everybody else that sooner or later they hit the wall, and it's actually their physical symptoms that force them to take a break. And oftentimes it's helpful if there's a loved one present who can corroborate this line of questioning. The biggest shock of my medical education was finding out that stress in childhood could cause illness in adults, and sometimes the onset of the illness is not until well into midlife. My very first patient in 1983 that had a medically unexplained symptom that was diagnosed and treated successfully by a psychiatric person, a psychiatric mentor of mine, didn't have onset of her symptoms until she was 35 years old, and it was linked to stress that had occurred in her life from age 4 to age 12. The common denominator in these patients is stress that has a tendency to knock a child's self-esteem down on a long-term basis. It's a difficult subject to get into, particularly if you don't know the patient well, so there's a series of questions that I use that kind of ease our way into this difficult subject. And these are shown on this slide. Just simply, did you experience stress as a child? And then I ask, how much on a scale of 0 to 10, with 10 being worst? And then almost no matter what number they give that stress, I'll ask, well, can you tell me what happened to you that makes you give it the number that you did? And that will frequently lead to a valuable discussion that most patients find therapeutic as well as a diagnostic for us. However, it's important to recognize that many people who survived adversity in childhood repressed their emotions about what happened to them, so that as adults, when they look back, they don't necessarily perceive the full impact of what happened to them. And so when they describe the events of their early life that you may find to be quite impactful, there may be very little affect that you hear coming from the patient. And they may deny that there is any ongoing effect on them of these early experiences. So an important question that I will typically add to this discussion is to ask the patient to imagine their own child or a child that they care about growing up with the same experiences. And frequently this puts an entirely different perspective on what they went through. When they imagine their own child or a child that they care about having these same adversities occur in their lives, all of a sudden the connection to the emotions around those experiences becomes a little clearer. And it's often a real revelation to them and gets them thinking along lines that they haven't before, that begin the process of connecting them with the emotions that they've repressed. For it turns out that those repressed emotions are being expressed somatically, and that's the reason for their symptoms. And the long-term treatment goal in these patients is going to be to convert the somatic expression of repressed emotion into verbal expression by having them do writing exercises or journaling, and we'll talk about that a little more later. What we're looking for in this sequence of questions is, again, treatment of the child that may knock their self-esteem down on a long-term basis. We're also looking for what is called a chronic, unpredictable, toxic stress, and we're looking for treatment of the child that may produce buried emotions, buried negative emotions such as anger, fear, shame, grief, or guilt. Here's a list of chronic, unpredictable, toxic stresses. These are sometimes been referred to also as ACEs, or adverse childhood experiences. There's an excellent website called acestoohigh.com with the 2 being TOO. And you can see the list of them there. And these are things to look for in the early life of patients with medically unexplained symptoms. The last 3 parts of the stress evaluation are simply to uncover the presence of mental health conditions that tend to be overlooked in primary care medical practice because they often present themselves with a physical symptom rather than with the patient complaining of a mental health issue. So many of my patients, the majority of my patients who clearly suffered from depression because they had symptoms such as early morning awakening, loss of interest in activities they formerly enjoyed, low energy level, low appetite, feeling like their life was not worth living, thoughts of perhaps doing harm to themselves. And yet those same patients who had one or more of those symptoms will often deny feeling depressed. So if the only question that they are asked is, do you feel depressed? Very often they will say no. They might admit to feeling stressed out, frustrated, exasperated. They may complain bitterly about the physical symptom that is their chief complaint. They may be desperate for relief of that symptom. You may find that the symptom on physical examination is rather underwhelming. You may find that the patient describes that physical symptom in rather vague terms. But if you ask specifically those more detailed questions that connect to secondary symptoms of depression, the diagnosis becomes clear. Similarly with post-traumatic stress, very few patients in my experience are specifically asked about this. Have you been through a traumatic, terrifying, or horrifying event at some point in your life? And if you find that yes, they have, and that the event took place shortly before the onset of their symptoms, then you've got a strong chronological link there. In other cases, the trauma happened at a time remote from the onset of the symptoms, and in those patients, typically there was a triggering event in their life that did happen right before the onset of the symptoms, and that triggering event is in some way linked to the trauma. A very quick example of that is a patient of mine who was sexually assaulted by 3 men a dozen years before the onset of her symptoms, but the day before the onset of her symptoms, she went to see a psychotherapist for the very first time, and that experience was so difficult that she vomited all over his carpet. And then the very next day was when her physical symptoms began. So a trauma, a clear triggering event, and then the onset of the symptoms very soon after the triggering event. And then finally, the anxiety disorders. 7 to 8% of primary care patients have this. The majority of them present not with complaints about anxiety, fear, worry, nervousness, but rather with a physical symptom. And the big clue here is that in these patients, the physical symptom tends to be much better or less frequent whenever they are in what the patient considers a safe environment. So a classic example is a patient of mine who was having attacks of bowel cramps and diarrhea, but she never had them at home. They were always away from home. Another patient of mine had stiffness in his neck and shoulders, but he never had it at home. It only occurred when he was away from home. Another patient had gastrointestinal symptoms at the time of her varsity soccer games in high school, but on the weekends when she wasn't playing a competitive game, she was asymptomatic. So that's the clue to look for in the anxiety disorders. And certainly you do want to ask them about worry, fear, and nervousness, and you'll usually get some indication that those are present, but they may have been present for so long that they don't particularly stand out for the patient. So a slide I often like to put in just to provoke a little thought that if we had a blood test for this condition, you can bet that all of us in healthcare would learn about that blood test and learn about its implications, and we would be diagnosing these patients routinely. But when you think about it, the fact that we don't have a blood test makes it significantly more challenging to diagnose this population, and consequently we should be spending much more time than we do studying their characteristics. This webinar today is aimed at trying to point you in the right direction so that you can learn from your patients in the months and years to come. Using these techniques, you won't necessarily diagnose every single person starting tomorrow, but as you interact with them, using this stress evaluation approach and the underlying ideas, your experience with this group will grow, and the range of them that you can successfully diagnose will get better and better over time. It certainly did for me. I spent the first 3 or 4 years working with this population, to be honest, rather confused. But as time went on, like anything else, as you gain experience, the skill level improves. All right, some treatment techniques. I know Tyler's going to talk about this, so I'm not going to spend a great deal of time on it, but this one is particularly useful in a busy clinic environment. When you start asking people about stress evaluation questions, you will find that a number of them will want to tell you their whole life story and spend the next 2 hours doing it. And for those individuals, you can assure them that you're grateful for their willingness to share the information, that it may well be very important, that you don't necessarily have time for a full discussion at that particular moment, but what you'd like them to do is make a list of all the stresses in their life, past and present, and bring the list with them when they come for their follow-up visit. And this is valuable for a number of reasons. Many patients find when they complete the list that it's much longer than they expected, and there may be a few revelations on there. They may also notice that certain stresses tend to cluster in particular areas of their life, such as a spouse or the workplace. And most importantly, they may start working to reduce the impact of some of these. And if they're successful, when they come back, they may report that their symptoms are already improving. And that gives you confidence that you don't need to do a massive diagnostic workup, that you can keep the patient working on their stresses, anticipating that their symptoms will continue to respond. For patients that take care of everybody else in the world, but have difficulty putting themselves on the list of those for whom they care, taking a block of time every week, 2, 3, 4, 5 hours if they can, purely for self-care, for activities that have no purpose but their own joy, is essential. These are, self-care skills are essential for human beings and may take months to learn. A lot of trial and error tends to be involved. There's a certain amount of guilt that needs to be overcome. Support from others in the household for this activity is often essential. But once a patient has learned how to take a break, learned how to add something to their life that gives them pleasure, that's a skill that they will have for life. And in the future, whenever their stress level reaches the point of causing physical symptoms, they will now know that they have something they can do to bring that stress level back down. It is an essential human skill to acquire this. And one other clue that I'll give you is that when I recommend this to people, they will often look at me and say, what am I going to do with that time? You want me to take 3 to 5 hours a week to do something just for fun? I don't know what that would be. And when you hear that from somebody, it essentially confirms the diagnosis that they lack those self-care skills, and that this is absolutely the right prescription for them. I'm sure most of the people listening today are familiar with treatment for current stresses, relaxation technique, meditation, mindfulness. I'm a big believer in yoga and other physical activities. My own drug was indoor soccer, which I played for over a couple of decades. All of these are obviously very useful for people that are struggling with stress in their life at the moment. For childhood stress, certainly psychotherapy is going to be significant for many individuals struggling with that. But there are a few things that you can do in a medical office that can make a big difference. And one of them is simply to point out that a hero in our society is somebody who has overcome a difficult physical or mental challenge for a good cause. And if you can bring a childhood stress survivor to an understanding that they have done a heroic thing by having survived those early experiences, then you are initiating a 180-degree flip in their self-esteem. That as that develops, it's going to be a key foundation for their future improvement. There's good evidence out there, particularly from a man named Penny Baker, Penny like the pasta, who works out of Texas, about the impact and value of various writing exercises for relief of physical symptoms. The one that I used the most in my childhood stress survivors was to ask them, when they felt ready, to write a letter to the person or persons who mistreated them, and not to mail it, just to write it. And oftentimes, once people started doing that, it proved to be quite cathartic for them. They oftentimes wrote vastly more than they expected to. And again, this is part of the process of converting the somatic expression of repressed emotion into the verbal expression of that emotion. And very often, the more that they can write, and the more that emotion that they put onto a piece of paper or into a computer screen, the less of that emotion there is to cause physical symptoms. And I've seen some, it doesn't always work, obviously, but I've seen some quite dramatic transformations. One of my patients took the letter he wrote to his father's grave and read it to him. He said it took him 4 or 5 hours to read the whole thing, and that by the end he was shouting at him. And his symptoms after that experience were just transformed, and he had been ill for many years before that. For many patients, reading evidence-based books about physical symptoms is quite valuable. My screen for literacy is, do you like to read? And if the patient says yes they do, then I can point them to several books. The paper that I had recently published in the CFHA journal, Family Systems and Health, has a table of those books in it. For my own book, just because conflict of interest has been in the news so much lately, I donate all the royalties to a nonprofit, so I don't have any financial conflict of interest with respect to my own book. And I think that is my last slide, so I will pass the control of the situation over to Polly and to Tyler. Thank you very much again for joining us.
Thank you, Dr. Clarke. Tyler, and I'm passing the screen to you now. And for the audience, while Tyler's pulling up his slide deck, I wanted to let you know that if you do have questions, we'll have some Q&A time at the end of Tyler's presentation today. You can ask questions in a couple of different ways. If you'd like to ask a question verbally next to your name in the attendee panel on the screen, you can raise your hand and I will unmute you and you can ask a question verbally. Or you'll see also in that control panel there's an opportunity to type in questions. So if you do have questions either from that you'd like to ask Dr. Clarke or Tyler, please feel free to type those in, and I'll relay those in the last few minutes of our broadcast. So with that, Tyler, I'll pass it to you.
All right, thank you very much, Polly, and thank you, Dave, for presenting the first segment. So as Polly stated earlier, I am a behavioral health professional getting my doctorate in medical family therapy, and I worked in a primary care setting for almost 2 years now. So early career professional, but what I really hope to do is tailor part of this presentation to behavioral health professionals. And with this segment here that we're looking at, of course, it comes from Dave's book, They Can't Find Anything Wrong, 7 Keys to Understanding, Treating, and Healing Stress Illness. So written by a medical doctor, but I'm hoping to give it a behavioral health perspective. So it branches into both professions. Okay, so 7 keys to treating stress illness. So what the goal of this is just working with patients who we believe might have medically unexplained symptoms. And these are steps we can follow with the patients or encourage the patients to do on their own in order to heal from their symptoms. And the first one, as we see here, is really help the patients understand that their symptoms can be diagnosed and treated. So again, I think Dave used the phrase earlier, quote unquote, it's all in my head, and this simply isn't true. The mind and the body are very much connected, and so we believe that these are very real symptoms that patients are experiencing, and just hearing their stories, it is very concerning for them, as it should be. But I think it can be very hopeful for people to hear that, not only acknowledge that they really are experiencing their symptoms, but there's a way that these symptoms can be diagnosed and treated. There is a path to better. And talking with Dave a few months ago, I brought up to him my concern that, Dave, maybe a patient of mine is experiencing pseudo-seizures, but how do I know if this is perhaps a traditional medical problem and not medically unexplained symptoms? And Dave really encouraged a collaborative care approach, meaning behavioral health providers work with the physicians and vice versa. Medical evaluation is still essential. While we might have reason to believe or that the stress, whether currently or in the past, might be causing the illness, still search for that medical cause. Okay, so this key, search for the sources of stress, it really encourages the patients to reflect and make sense of what they're experiencing. So encourage the patients to become their own detective. When am I experiencing these symptoms? When am I not? When is it worse? When is it better? Has there ever been a time in my life that I've also experienced them? What was going on in my life then? So with that self-reflection, hopefully the patients will not only be able to understand by themselves, but hopefully even be able to relay their experiences to behavioral health and medical professionals as well. And these are things that patients can do either just in their own thoughts or even writing things down. So part of this will write down their detailed illness description. As stated earlier, what do the symptoms look like? Look for patterns. And also you can recommend that the patients look through the stress inventory, whether current or past stressors, just to see what might fit as a cause for the patient's current symptoms. And with the second to last point, it's important to remember that stress can accumulate. I have found that there is such thing as the straw that broke the camel's back, and sometimes that can be tough for people to recognize when they have a lot on their plate. And the last point, I have found it very helpful to use this one because sometimes when patients go through sometimes horrific experiences, there's almost like a disconnect between the affect and the memory. And it might be easier for that patient to imagine maybe their daughter, granddaughter going through what the patient did growing up, and helping to helps make that connection between the affect and those experiences, develop empathy for themselves. All right, our third key, care for yourself. As Dave stated earlier, that self-care can be crucial. I think even before being introduced to this special interest group and medically unexplained symptoms in the psychotherapy field, definitely self-care, both as yourself as a profession and encouraging patients to do, definitely has been part of my education. So an interesting way to frame it is symptoms can be a way the body is asking you to take care for yourself. So what can a patient do maybe just a few hours per week where they can allow themselves to do something just for enjoyment? As Dave said, he did indoor soccer. Myself, I like to cook to music. Patients, of course, sometimes they already have things that are built in. You might just encourage them to do it more often. But sometimes it might just take some trial and error. And that's okay. You can even frame it to them as, this might take some time. And in my experience, some people might even feel guilty taking care of themselves. And that's just a normal part of the process in order to really eventually experience that enjoyment after some time. So this being able to set aside some time for self-care, it will, of course, require some sort of boundaries. And if you work with a patient's spouse, significant other, family members, you can even work with them to create the space that patients need to take care of themselves. And a lot of times families are even very much willing to help the patient because the patient has been suffering from a cause that they might not understand. And so family members will more often than not be on their side with this. Learning to say no to the needs of others. Of course, that can be toughy. A lot of times the people that we see are the caretakers in the family. Maybe to a parent that is sick, maybe that they say that's just their personality. They just take care of others. And one way you can phrase it is, I'm not asking you to be the number one on your priority list, but just put yourself on that list. So you don't have to take care of yourself 24/7, but just take care of yourself at least part of the week, just as you would a child or maybe a friend, a loved one. So take personal time to learn how to enjoy it. Again, you might want to preface this to patients like it might take time. It might take some trial and error. And this might be helpful as a way so they don't try once to, say, garden, and then once they don't feel enjoyment, then they just stop. There's some sort of expectation where, okay, this will take a while, but I can get through this. I will get to better. I will be able to enjoy some activity eventually. And the Hero Award. I think in my experiences, it's been astounding what some people go through, just the resilience, and they don't give themselves credit for not only surviving sometimes awful experiences, but doing well throughout those experiences. And so one thing that I encourage patients to do is, maybe write a list of achievements. specific ones that I've encouraged them to do is write about how you made it past your abusive experiences in childhood. Maybe the patient might be really proud of their grandchildren or their marriage. They likely had some part in not only their grandchildren's life, but of course they're going to have some part in that marriage. So just really have them recognize their own role in the good things that they have in their own lives and in the lives of their others around them. So as last point states, it can be challenging. Sometimes these patients, they don't give themselves credit for things that are good in their lives. Sometimes they've been through horrific experiences. And so just some sort of acknowledgement of what they've gone through, that strength, it can stand in contrast to some of their experiences. So this might be difficult for patients to learn, but it is still very valuable. Right. Key number 4, get right by writing. So this has been helpful because sometimes you don't have time in encounters. I'm speaking to both behavioral health professionals and physicians. You don't have time to do everything. But this is something that patients can certainly take with them outside of that 20-minute encounter, that 1-hour encounter you have with them. Encourage them to sometimes just start writing. Maybe you can write about particular events or maybe to particular people that have harmed you or failed to protect you. So again, maybe as a provider, if you notice any significant events in that person's life that may be contributing to the patient's symptoms, that might be a good event to encourage the patient to write about. And the last point, as stated earlier, it can be helpful having the patient imagine a small child, for example, one that they care about, child, grandchild, go through the patient did and write a letter of support for that child. Again, this helps patients build a sort of empathy for themselves. And really, sometimes patients, as children, again, went through horrible things, and it's almost like there's an expectation where the patient knows they were 5 years old during this difficult time, and they expect themselves to handle it like an adult. And by imagining that small child, that they, again, grandchild or their own child, go through what the patient did, it helps kind of separate that age gap. The patient might find that they cannot expect themselves to have handled their difficult experience any better than they did. Key number 5, employ appropriate therapies. Behavioral health providers, this is us. So one thing, I'll actually go into this a little bit more in depth later on. So I'll skim it here. But some things you can do is help patients recognize some of the false beliefs that they have about themselves. For example, or like just a moment ago when I was stating, sometimes patients believe as a 5-year-old they should have handled a difficult situation just as effectively as an adult would. And that's clearly not realistic. Helping the patient recognize some of their achievements, alter patterns of self-criticism, and help guide patients and help patients see the healthy relationships in their life. Physicians or even behavioral health professionals, you can perhaps consider a referral to psychiatry or use of psychiatric medication. And then there's also other adjunctive healing arts, massage. Patients may or not be open to these, but if the patient feels that there's some benefit, it might be worth considering. Key number 6, overcoming hidden resistance. So this is a way, as as stated earlier, sometimes when patients start beginning their self-care activities, it can be difficult to not only start doing, but sometimes patients can fall out of it. Sometimes patients fall out of writing, maybe get back into unhealthy relationships. So just really encourage the patients to follow through and continue doing some of those things that have been helpful for them in the past or seem to be helping currently. Okay, and key number 7, become the person you were always meant to be. A lot of times our patients, again, go through very difficult times, and it can be tough for people to go through very difficult times to not see that as a reflection of who they are as a person. So as a provider, what you can take from this is helping the patients see themselves as good enough to have some esteem, to be able to accept care and affection from loved ones. Maybe discover that there are parts of each of us that are appealing, that are good, and see how this fits in with other people. So a patient doesn't think, I have been through a traumatic experience, I am tainted. It's, I have been through something that's been difficult, and I still have a connection with others. Again, I think self-empathy is definitely a message that I've been trying to convey. And this, the second to last point, of course there are some things about ourselves that we cannot change, and that's just how things are. Maybe encourage patients to accept the things that they cannot change and change the things we can. And by following these keys, this can be definitely a helpful guideline for our patients. Okay, and this segment of the presentation, it is on educating behavioral health providers on how to speak with physicians about medically unexplained symptoms. So this is more tailored to behavioral health providers in a medical setting. However, it is still applicable to those who work in other settings. So behavioral health providers, if you can communicate with physicians, whether face-to-face, letters, telephone, etc., this portion of the presentation is still relevant for you. And it's broken down into 2 main parts. First, educating physicians on MUS, and second, clarifying your role in regards to MUS treatment. Okay, so before jumping in, again, I've been practicing in a medical setting for 2 years, and I have undoubtedly found that relationships are essential for good treatment of patients and working as a treatment team. For example, I'm working under the assumption that as a behavioral health provider, you can't, the first day that you start working in a setting, provide all this information regarding MUS to all the other providers and expect them to really hear and understand what you're saying, but perhaps also be willing to make assessment changes. Maybe what you say might change in the workflow in your clinic. And by just the first day at work suggesting all this, it's, in my experience, too much too soon. So really building some of those relationships are essential for your knowledge of medically unexplained symptoms to be heard and understood. I think part of building that relationship is just being a good team player, being able to work on a treatment team. So some of the points that I just thought of are just knowing the basics of each provider's role. What does the RN do versus the LPN? Who rooms the patients, and what are the questions that they ask when they room the patients? A physician is a DO instead of an MD. What does that mean? And the more you're able to understand what each person does, the more you can tailor your message of MUS. Again, know your clinic's workflow. Know how treatment information is communicated in the clinic that you're at. Is there any communication of treatment information? Maybe it's just done through for example, an electronic medical record message, or perhaps face-to-face after a consult's the norm. Educate others on your role. Behavioral health providers, I think sometimes we feel misunderstood as a bunch. So I really would encourage you to, in some way, educate others on what you can and perhaps what you can't do as a provider. And also, the last point, it's more of an attitudinal one. Be a team player, sense of that give and take, working for the common good, that cooperation. I think sometimes in a clinic or medical setting things get stressful, but I think providers most of the time can recognize when you're doing your utmost for the patients and for the team. Okay, collaborative MUS treatment. So this is the portion that is for educating physicians about MUS, and a large part on speaking with physicians about MUS may likely be educating them on the topic. And I won't go totally in depth in some of these points since I hit some of them earlier and Dave did as well. But you'll really want to tailor this to the physician you're speaking with. You might be speaking with someone who's very much on board with medically unexplained symptoms like this. They might think, yes, this does exist. Yes, I think writing behavioral health provider self-care can be part of the treatment plan. Or maybe you're speaking with somebody who this is a new concept for them, that somatic problems, that MUS, that psychophysiologic illness can be bettered somehow. But just to reiterate a few points, prevalence. Again, as Dave said earlier, it's responsible for about 30% of primary care medical office visits. So this is a common and significant set of symptoms. Causes, again, this was reiterated earlier. Treatment. Assessment, I think this is very much an important one. A lot of times physicians are the first medical professional who has been in contact with patients who present with MUS. So part of what you can do is encourage physicians to gather a history of symptoms, or even encourage them to do a stress evaluation. And also one line you can use is to encourage physicians to really acknowledge that patient's concern or worry. Just because the test came back negative doesn't mean a problem doesn't exist. I think for some people that can be very reassuring to hear, like, what they are experiencing, it is real. It's not just, again, quote unquote, all in your head. So one of the things that interests me most about MUS is just that mind-body relationship connection. So I think one thing you can do, you can say to patients, both as a behavioral health provider or encourage physicians to do, is to take this biopsychosocial approach, both with assessment and also treatment. And one thing you can help educate patients on to help bridge this gap is explain to patients that we know illness and physical symptoms have multiple causes. Lifestyles and stressors play an important role. So we'll look at the influence of everything in your history. So we're like, it's not just in your head. These aren't just physical symptoms. They interact. So again, that bridges the gap between the patients just looking for a test to validate what they experience, to having them look at maybe their own past difficulties or current difficulties contribute to what they're experiencing. And also, behavioral health providers educate physicians on how you'd like to be introduced to the patient. My recommendation is, if possible, in-person introduction is best. It seems to be pretty good at building rapport. and also communicate to the patient that you will be communicating with the physician regarding their symptoms, because of course the mind and the body relationships are connected. So you want the treatment to incorporate all these elements as well. All right, and lastly, behavioral health providers explain what you were trained to do. And I found this part really encouraging for us. So a lot of these factors that I have listed here, they either are potential causes of or problems caused by medically unexplained symptoms. So I'm not really seeing anything here that sticks out to me that is out of our wheelhouse necessarily. Maybe family therapy might be outside the wheelhouse of some behavioral health professionals, maybe. But most of these are very much, I think, we're comfortable with addressing. And so I think that's encouraging for you, just so while it will take some time as a behavioral health provider to be able to tailor this information to different patients you see, becoming more comfortable assessing yourselves. So it's not just physicians assessing patients, it's also you assessing patients. But this is something that is doable. And again, I would say if one thing you can even brush up on or learn more about is the 7 keys to treating stress illness. And before I end, I would say the last point of mine would be behavioral health providers, after treatment begins, please keep physicians informed about progress. A lot of times physicians are very happy to hear that a patient of theirs is improving, or perhaps if the improvement isn't coming, you can work with physicians to just both through the more traditional medical assessment as well as the psychosocial assessment for what might be causing this. And Polly, that's all I had.
Wonderful. Thank you, Tyler. It looks like we probably just have a minute or two for questions. So if anyone does have a brief question you would like to type in and ask one of our presenters today, or would like to ask a question verbally, you can raise the little hand symbol next to your name and I can unmute you. Do we have any questions in this last minute or two? I would like to remind everyone again that this has been recorded and will be on the CFHA webinar within the next few days. Our speakers have generously offered to make their slide decks available to you all, so we'll have those up on the website as well, and we'll send you all notification about that as soon as we've got them posted. So it looks like I'm not seeing any questions at this point. If you do end up having a question, please feel free to email us at, you can either email me at pkurtz@cfha.net or all of us at info.cfha.net. There was someone who just typed in a question and I inadvertently deleted it while trying to open it. It has not been my day for technology, so forgive me. If you wouldn't mind resending that, we'll forward it on to the speakers. Again, thank you, Dave and Tyler, for this very informative presentation today. We'd like to invite everyone to tune back in. I believe we have another webinar scheduled next week on complexity, and we'll be sending out information and posting that on the webinar as well. Thank you all for joining us, and we will be in touch about the recording. Have a wonderful afternoon.
Thank you, everyone. Thank you, Polly.
Thank you.